This morning, I was seeing patients at Bellevue at a regular clinic session. You know, a busy day, lots of patients, lots of medications, lots of illness. And like many other doctors, I'm always wondering, am I really as good as I could be? Should I be improving a little bit? And I think we do certain things to make ourselves better, continuing medical education. I go through these periodic kind of spring cleaning frenzies. Maybe I'll pull out my physical exam book and commit myself to learning how to palpate the spleen again, or I'll swear that I'm going to read the New England Journal of Medicine every week and not just scan the headlines. A couple months ago, I recertified for my boards, and so I memorized 2,000 pages of facts, which I retained for about 72 hours. But I never really thought much about how I speak with patients. And before I wrote this book, I viewed communication not much differently than I viewed breathing. You know, I kind of did both automatically. I only really paid attention if they ceased. And as I started writing this book when I had the opportunity to interview a doctor and a patient, a pair who'd been together for a couple of years. And what was fascinating is that when they told the story of the same events, it was completely different, almost like two movie cameras on one set of events, or almost at times like two different movies. And I was fascinated by the gap between what patients say and what doctors hear, and vice versa. And when we think about what matters most in the doctor-patient interaction, and we have, lots of high technology now, which I love, but as I spent time reading the research and talking with doctors and patients, I really ended up concluding that the doctor-patient conversation is the single most powerful diagnostic tool that we have, and often one of the most powerful therapeutic tools that we have. And it feels anachronistic to say that, given the age of, genomic medicine, and we have fancy scans and MRIs and now chemotherapy that can act exactly on your tumor. Yet the way we communicate is so important and often gets such short shrift. I mean, when you look at what insurance companies pay for, it's not time to talk with your doctor, but it's what procedure you got, what tube went into which orifice, or which surgery you had, or the medications that you get. But the idea of doctors and patients speaking is considered, that's kind of a nice little affable bonus, a little good bedside manner. But I hope that in writing this book, I'll help doctors and patients, and maybe insurance companies, and perhaps those who are redoing our healthcare as we speak, might come to value the time that doctors and patients actually talk together as something worthy of counting and reimbursing for, and valuing it in our time. So I wanted to start by sharing a patient of mine, I've changed the name and some details, who exemplifies some of the challenges in communication. It was late on a Thursday evening when my office phone rang. It was Omar Amadou. "I am not feeling well," he said. "I need to see you, Dr. Ofri." The clinic was already closing up. I'd already turned off the computer. "I need to see you now," Mr. Amadou said. The annoyance in his voice was apparent even with his thick West African accent. In the few months I'd known Mr. Amadou, I'd probably fielded 50 phone calls from him. He always had something wrong, something bothering him, or needed a form filled out, a medication renewed, and he always needed it right away. He constantly showed up at the clinic without an appointment, but he also had a severe heart condition, even though he was only 43. At our first visit, he'd hauled out a tome of papers from a cardiologist in Pittsburgh that detailed a severely malfunctioning heart, one that required a pacemaker, a defibrillator, and several stays in the ICU. So when he called on a Thursday evening, I took his concerns seriously, despite the irritating tone of his voice and my depleted reserve of patience for him. I questioned him about his symptoms to suggest if he had congestive heart failure or an arrhythmia, things I sent him right to the ER for. But he had no specific symptoms, just a vague sense of not feeling well. I wasn't scheduled to be in the clinic the following day, Friday, but because of his poor heart, I didn't feel comfortable waiting until Monday. "Please come to the clinic tomorrow," I said. I explained that I wouldn't be there, but he would be seen by one of my colleagues. When I arrived on Monday morning, there was an indignant voicemail message from Mr. Amadou. "I come Friday, but you know there, so I go home. I need to see you." Ugh. Either He hadn't understood what I'd said, or he was simply being stubborn. The next 3 days were a series of missed phone messages between us. If he was feeling sick, I told him, he should come to urgent care right away. If he didn't feel too bad, we could get him a regular appointment. He left repeated voicemails saying, "I need to see you, Dr. Ofri," seeming not to acknowledge any of my messages to him. And whenever I called back, I only got his voicemail. Midday the following Thursday, just as I was saying goodbye to the last of the morning patients, Mr. Amadou popped into my line of sight. Tall and lanky, dressed in a powder blue tracksuit, he signaled anxiously at me. "I need to see you, Dr. Ofri," he called out. "It is very important." I was unprepared for the rush of anger that flooded me. Mr. Amadou could just walk in the door and assume I would drop everything and give him an instant and medical evaluation? Yeah, he had a bad heart and all, but that didn't give him a free pass to be so demanding. Obviously, whatever was bothering him couldn't have been so bad, because he'd chosen to spend the week trading messages with me rather than coming to the clinic. I needed to draw a line. "Mr. Amadou," I said, "you cannot just show up to the clinic without an appointment." "I come here to see you, Dr. Ofri." He said, "Yes, I know," I said, "but I have other patients with scheduled appointments. If it's something that's urgent, you can come to the walk-in clinic today. Otherwise, you need to make an appointment like everyone else." "I no see other doctor," Mr. Amadou said. "I only want to see you. I need to see you today." I knew that if I gave Mr. Amadou a medical visit right now, I'd reinforce the idea that he could just walk into my office at any time. He'd be at my doorstep every week. But I also understood the severity of his cardiomyopathy. This was not the type of patient I could take a chance on, annoying or not. "Okay, Mr. Amadou," I said, sighing heavily. "Just a quick visit. Next time, you have to make an appointment." Mr. Amadou smiled broadly as I led him from the waiting room, and I knew I was going to regret this decision. He'd now figured out how to get an instant appointment, just be annoyingly persistent until I caved. The medical assistant was about to leave for lunch, but I gave him a beseeching smile. "Could you please do a quick set of vital signs of Mr. Amadou?" I asked. He hesitated, raised an eyebrow, and then finally assented. With relief, I gestured to Mr. Amadou to enter the assistant's room. Mr. Amadou took 2 steps and then paused in mid-footfall. He seemed to hold his lanky body aloft, almost as though the muscles were debating whether to move it forward or backward. But it was all an illusion as he collapsed to the floor with a heart-stopping thud. I dropped to my knees and pressed my fingers to his neck to check a pulse. "Mr. Amadou," I shouted, "can you hear me?" He was breathing rapidly, slumped against the door frame, his legs stretched out into the hallway. He placed his right hand over his chest. "My heart," he said faintly, and I was swamped with a horrific wave of guilt. I called for oxygen in a stretcher while I crammed my stethoscope under the jacket of his tracksuit. His pulse was 130. His fingers were so cold that the oxygen saturation monitor could not pick up a reading. We loaded his listless body onto the stretcher and began wheeling him to the emergency room. Disconsolate, I held Mr. Amadou's hand as we pressed down the hall, striding briskly to keep my pangs of remorse at bay, praying that he was going to be okay. We rolled him into the triage bay of the emergency room, and I explained the situation to the ER doctor. As we finished the handoff of medical care, I turned back to Mr. Amadou. I took his cool, clammy right hand in my 2 hands and gave it a squeeze. His fingers were frigid. I apologized for berating him in the waiting room and for all of our miscommunications during the week. He opened his eyes to my words, but was too breathless to speak. He nodded slightly and then squeezed my hand weakly. I trudged back to the clinic, staring down at the linoleum floor the whole way. I couldn't hold back from dissecting in minute detail the events that had just transpired, trying to figure out the mistakes. Mr. Amadou had been demanding, perhaps unreasonably so, and I'd put my foot down, maybe a bit too decisively. But maybe the problem was more basic than that. Maybe we just weren't hearing each other. George Bernard Shaw supposedly said, "The single biggest problem in communication is the illusion that it has taken place." So as I began going into the research, I really became intrigued about how we actually study communication. The field of communication research comes from English teachers who were interested in public speaking. And they promulgated the idea that the way you convey information is that the speaker stands up, says what they have to say loud and clear, and like sending off like a basket on a zip line to the audience, and they unpack it and they get the information. And there's some fascinating studies done by a researcher named Janet Bavelis in the west coast of Canada. And she was interested in how the listener affects the speaker. She did a very clever study with some college students, and she took pairs of students, and one student was told to tell a story from their life, some near miss, something very dramatic that almost happened or almost fell or almost lost their life, and the other person had to listen. So with one group of listeners, they told them that while the speaker was speaking, they had to count in their head the number of holidays, school holidays, between now and Christmas, and it was February in the exam, during the study. So while the speaker spoke, the other students thinking, okay, there's Valentine's Day, MLK Day, Columbus Day, and trying to figure out how many holidays there were off. So unsurprisingly, they were lousy listeners. They hardly noticed what was being said. They didn't do much in the way of sort of generic nodding to let you know they're listening. And they gave almost no specific responses, like responding to key parts of the story. For the second set of listeners, they had those listeners press a button each time the speaker used a word beginning with the letter T. So these listeners had to listen very attentively and mark each time there's a word with a T. Now, these speakers actually did pretty well with the non-specific responses like and yeah, but they were equally bad at giving specific responses. So they were listening hard, but they weren't actually hearing the story. But the most amazing thing to me was the effect on the speaker. As the speaker began to talk and realized that the person wasn't listening, they began to falter. They would circle back and tell the story again, because it was a dramatic near-miss story, and the listener wasn't getting it. So they'd say it again, and the story would begin to break down and essentially collapse into nothing. And so she termed the idea that the listener is a co-narrator. They help the speaker narrate the story. And that when they listen well, the speaker tells a better story. And when they listen poorly, the story breaks down. And I think this has a lot of relevance to doctors and patients. Because when a patient tells the story, and I think many of you may know the situation, you're telling the story, and if the doctor is checked out or they're on the computer looking something else up, you kind of stop. You feel a little silly speaking into the air. And if we listen better, then the story comes out more whole and much better. So one of the things doctors do is we interrupt patients very quickly, something like 8 to 10 seconds. You say, I'm having this kind of pain. Oh, when did it start? Oh, what does it happen? What makes it better? What makes it worse? Right? We just can't help ourselves. So I wondered, how long would a patient speak if you didn't say a thing? Just let them go. And I polled my colleagues. So I'm like, 5 minutes, 10 minutes, 20 minutes, forever. I would never do it with my patients. So I found a study that actually did that, a Swiss study, where the doctor said, what can I help you with today? And the patient just spoke, and the doctors didn't say a word other than nod and mm-hmm. And the average monologue for the patient, 92 seconds, right? Hardly the deluge, tsunami that we fear. But I thought, okay, I'm going to try this in my clinic. So the very next day, I did it. So for every patient, after I said, what can I help you with? I turned on my stopwatch and I didn't say a word, just took notes as they spoke and I just nodded. So the first patient was about 38 seconds, but they were pretty healthy. And the next patient had a little bit of back pain, a minute and a half, not too bad. But then came the kicker, Josefina Vargas. A teacher in her native Argentina, Josefina Garza was saddled with a vast array of insoluble pains, compounded by anxiety, depression, and irritable bowel syndrome, plus a demanding mother to care for. Exactly the type of patient who can drown you with her list of complaints. I love her droll observations about New York City's pretensions of culture, which of course could never measure up to the sophistication of Buenos Aires. But if I let her talk uninterrupted, this visit would unfurl like a Borges labyrinth. I'd hear a dizzying list of symptoms from every organ, a rundown of her mother's medical ills, plus a stinging critique of the Metropolitan Opera's soulless production of Turandot. I wouldn't be able to provide any easy solutions for her symptoms, and I'd be forced to explain the decisions of her mother's doctors, as well as the artistic director of the Met, who desiccates Puccini on a routine basis. Both of us would be in a sour mood by the end, and the whole thing would turn out to be a sprawling, onerous mess, worthy of an atonal Schoenberg opera, which Ms. Garza, of course, would excoriate on philosophical grounds. But I promised myself I'd let every single patient talk today. If I eliminated the so-called difficult patients, then my data, however informal, would be flawed. I girded myself for battle and asked Ms. Garza, "How can I help you today?" and reluctantly clicked on the stopwatch. "Every single thing hurts," she said, "from my toes to my head. There were shooting pains in her gums. Her scalp was painfully sensitive. Neck pain was radiating down her spine. Her mother had insomnia and was up at all hours of the night complaining." Each time she paused, I said gamely, "Anything else?" And there always was. "I'm only 45, she said, "but I feel like I'm 85. Every step hurts, and my head feels like it's swollen to 5 times its size. It's like I'm walking through molasses." I scribbled a few notes on paper as she talked, but maintained eye contact with her the entire time. "Let's get everything on the table," I said bracingly. "Every last symptom, and then we'll figure out where to go from there." I let her keep talking until she'd fully, truly, absolutely come to the end of all she had to say. In the dip of silence, I reached over to click off the stopwatch. I estimated 8 minutes, 10 minutes had transpired, but in fact, it read 4 minutes and 7 seconds, and the Met had come out unscathed. I suppressed the urge to jump up and say, "Wow." Instead, I turned back to Ms. Garza and said, "Is that everything?" And she nodded. I showed her the list I'd been jotting down. When viewed on the page, it actually didn't seem so overwhelming. It was long, but it was finite. Ms. Garza had already had the $1 million workup, which was all negative. I explained to her that she had something going on. "Medicine is very poor at explaining pain syndromes," I said, "but that doesn't mean we can't go ahead and start treating the symptoms." We went down the list together, trying to identify which pains might be helped with ice packs, which might be treated with local heat and massage, which might be best treated with physical therapy, which might respond to pain medications. We talked about how antidepressants could be helpful and that seeing a therapist could decrease her stress. We discussed the critical role of exercise in treating chronic pain, and then we wrote up a plan. At the end of the visit, which didn't run over time by too much, she said something that I'd read about but never actually heard a patient legitimately say. "Just talking about all this," she said, "has made me feel better." I wanted to jump up and sing an aria, which luckily for all parties involved I refrained from. But I was in the process of realizing something else. Just talking it all out made me feel better. I think that most doctors, if they were really honest with you, would say we hate patients like Ms. Garza. Those patients who come in with 1,000,000 complaints, a list a mile long, 50 questions, 20 medications, 16 things downloaded from the internet. We dread these patients. Of course, we say we want informed patients. We want them to take, control of things. But it's really hard. You have 15 minutes and a lot to get through, especially when we feel like we can't do very much because so many of their issues relate to their life in general, their socioeconomic issues, the stress in their life, their lousy job, their bad shoes, things we often don't have much role in affecting. And these are the patients who get shunted from doctor to doctor, because I think that we doctors, we try to turn off the spigot as expeditiously as possible, get them to stop talking, because the more they say, the more we have to deal with. And so what I learned from Ms. Garza, that actually letting it all come out, in fact, made the visit more efficient. It felt like a lot, but once we got it all on the page, it really wasn't so bad. And we couldn't handle it all today, but then we said, all right, let's do the top 3. Let's save the next 4 for the next visit. And then I think she felt less anxious that she wasn't going to have to jump in with one more thing, that we could get it all out. And then she, I think, was able to calm down a bit. Now, it's interesting. We do a lot of research in medicine on the effect of the medications we prescribe, the tests we do. We're always interested in the outcomes of what we do. We want everything to be evidence-based medicine. But is there any evidence for how we speak? Can how we as doctors talk to patients change the medical outcome? There was a landmark study back in 1964. Patients were going for abdominal surgery. And if any of you have ever had abdominal surgery, you know that post-op pain is a terrible problem. And And we tend to treat post-op pain with narcotics. They work well, but of course they cause a host of problems. Nausea, vomiting, constipation, respiratory arrest, and loss of consciousness. So minimizing narcotic use is an enormous priority for people in the medical profession. So what this very simple study did is they took 100 patients who were going for surgery the next morning. And the night before surgery, the anesthesiologist goes and talks to each patient, explains what's going to happen. But for half the patients randomly chosen, the anesthetist also gave a 20-minute discussion about post-op pain. They explain what the pain is, how it's often caused by clenching muscles, where the pain might occur, when it might occur, how you might relax your muscles to ease the pain, and if that didn't work, how to call the nurse for pain medications. That's it, 20 minutes. And the surgeons who operated and took care of the patients had no idea who was in what group. And I think we might be able to guess that those patients had a little better pain relief. But what was amazing is that they needed half the amount of narcotics than the other patients. That's an enormous, clinically significant decrease. I mean, for me as an internist, anything that decreases the amount of constipation that my patients get is worth a gold medal in and of itself. But more amazingly, those patients were discharged 3 days earlier than the other group. In today's dollars, that's almost $15,000 in cost, plus 3 days in the hospital when you could be at home. So a simple intervention of speaking to patients, of explaining what's going to happen, no rocket science here, really changed outcomes in a meaningful way. There's a more recent study involving physical therapists and back pain. And it's one of my favorite studies because back pain is probably the number one thing I see in clinic. People come in, everyone's back hurts. And, it's just part of life, but it's probably the third leading cause of doctor's visits. So it uses an enormous amount of resources, time, money, medications, physical therapy. And so when I send my patients for physical therapy, which is my preferred mode of treatment, I always think in terms of, the exercises the physical therapist will do, the massage, the ways of lifting that they'll instruct the patient on. Sometimes they'll use electrical stimulation, which can be very helpful. What I don't think about is how the physical therapist communicates with the patient. And this very clever Canadian study took a bunch of patients with back pain going for physical therapy and divided them in half. Half got the treatment, the electrical stimulation, and half got sham. You hook the whole thing up, but don't even turn it on at all. And they said, this new machine is very quiet. Doesn't make any sound at all, right? With the latest technology. And the people who got the stimulation, they did better than the placebo group, right? They had about a 25% reduction in their level of pain. And the people who got the sham stimulation, they had a 25% reduction in pain. So just having the whole setup relieved pain. But those who got the actual stimulation had a 45% reduction of pain. So the stimulation actually works. But then they divided each group in half again. And half the physical therapists were very engaged with the patients. They asked them about the pain, how the pain fits into their life, how it limits their activity. They expressed a lot of empathy. They really actively tried to make a good doctor-patient connection. They expressed optimism that the pain would get better. And those patients who got no stimulation at all, the machine was off, but got the engaged therapist, had a 55% reduction in pain. That's more than the machine itself, by itself. What we say was more powerful than the machine. The patients who had both the machine and the engaged physical therapist had a 75% reduction in pain. They really benefited. And again, it didn't take very much, right? It just took a little bit more attention to speaking. The visit wasn't any longer, but the act of the physical therapist connecting, communicating, empathizing made a real difference in the patient's pain. And you can say, this is just hokey placebo, and it might be. But if you have back pain and you get 75% reduction in your pain versus 45%, that is meaningful. And I want my physical therapist. One of my patients once said, I don't care if it's a dill pickle. If it makes me feel better, reduces the pain, I'll take it. And the idea of placebo, comes up. Is that something that's unethical to give a patient placebo? Does it actually help? I'm going to share with you just one last story. And this story takes place when I was a resident. And so I trained at Bellevue during the height of the AIDS epidemic. And so the AIDS ward at Bellevue was a very, very busy place. It was well past midnight on the AIDS ward at Bellevue. Despite the late hour, Nurses and doctors were still rushing about at full speed as the admissions continued to surge in, each more feverish and emaciated than the previous. But even the AIDS ward eventually quieted down at night, except, that is, for the Howler. The Howler was a patient in his 30s who'd earned his nickname for his nightly bouts of wailing. He was already getting hefty doses of pain medications, yet he kept screaming to the nurses about his pain. This went on night after night, despite extensive medical evaluations to see if there were any missed explanations for his pain. Nothing seemed to help, and the nightly yowling was agitating the other patients, not to mention driving the nursing staff to distraction. The head nurse paged me 3 o'clock in the morning. "You have to do something," she said, "before somebody strangles him." Reluctantly, I trudged back into the patient's room. I'd been on my feet for more hours than I could count. This was my 4th visit to the Howler that night. By this point, we were both pretty exasperated with each other. He was sullen and cranky. I was exhausted and at my wit's end. I watched the patient writhing in pain and felt bad for him, but his moans burrowed into my brain, deflating my last 3 functioning neurons. I rummaged around in my pockets to see what I could come up with and pulled out a vial of saline. On a whim, I plucked a syringe from another pocket and slowly peeled back the wrapper. Stepping in closer to the patient's bedside, I cocked back the syringe and drew up 1 cc of plain saline. "You know about Tylenol, right?" I said to the patient, who was continuing to twist within his bed sheets. "And you've heard of Tylenol number 3, the kind with codeine, right?" I leaned forward and held up the liquid-filled syringe close to the patient's face. "There's even a Tylenol number 4. I slowly removed the cover off the needle, and it glistened in the fluorescent lights. "But this," and here I paused for dramatic effect, "this is Tylenol number 5. The patient stopped howling and gave me an interested look. Without a word, he lowered his pajamas and allowed me to inject the saline into his gluteus maximus. I disposed of the syringe in the nearby sharps box and then pulled up a chair to his bedside. The patient and I waited together, allowing the minutes to tick unhurriedly by. After what seemed like a mutually agreeable time, I stood up and bid him good night. The patient put his head on the pillow and promptly fell asleep. The ward was silent for the rest of the night. I did feel guilty that I'd committed an outright deception with this patient, something I knew was a true no-no. On the other hand, it was the first time he got a full night of sleep, to say nothing of all the other patients on the wards and the rest of the staff. The nurse, by the way, bought me coffee in Danish the next morning. She was my best friend for the rest of residency. And the idea of placebo is a fascinating thing. We think of placebo as the sugar pill we use in a clinical trial, the nothing part. But if you look at the data around placebo always has an effect. And before we had antibiotics or MRIs or chemotherapy or lung transplants, placebo is what doctors did. It's what shamans did. It's what witch doctors did. It's what all people in the medical profession did. We had nothing else. And in many cases, it was remarkably effective. Many people get better with placebo. And placebo can be a number of things, and we know that it probably activates the endorphin system. A very interesting study was done just on the techniques of placebo, where they took normal volunteers and gave them a painful stimulus, a hot pad on their calf, and then dripped an IV of pain medication equivalent to fentanyl to relieve the pain. And they had their heads nicely in a functional MRI. And so first they gave the painful stimulus, and they let the fentanyl drip in unannounced, and the patient's pain got better afterward. Right? The fentanyl certainly worked. Then they gave the painful stimulus, and they said, "And now we'll start the pain medication." And their pain got even better, about twice as good, just by making that little announcement. And then they gave the painful stimulus again, "We're now going to stop the fentanyl because we're worried that there's a rebound for increase in pain." But they still gave it silently. And in fact, there was no benefit at all. The entire effect of fentanyl was wiped out by saying, "It's not going to help you." And when they did the fMRI, they could see that the pain regions of the brain light up, whether you give the pain medication or just say you're going to get the pain medication. So it seems to have a neurological effect. And again, if it works, why not? As long as we're not, skipping out another, a necessary medication. And so I kind of look at placebo differently now. I used to think it's sort of unethical, but now I think it's unethical not to give it a try in situations where someone's not getting relief by traditional means. And so one of my favorite placebos now is the multivitamin. And I always have patients come in and say, I had a patient this morning say, I need a multivitamin. Well, give me more energy if I take a vitamin. And of course the answer is no. There's no study to support that. And I would normally say, hey, take it if you want. It's just going to be a waste of your money. And if you don't have a vitamin deficiency, it's useless, but take it if you want. But now I say, many of my patients say that taking a multivitamin gives them a lot of energy. It's not a lie, because lots of my patients do say that. And I let them take it. And if it helps, great. I've made them better. As long as I'm not skipping out on their blood pressure medication, I don't see any harm in that. And you can let them know that it may work as a placebo. And in fact, surprisingly, open label placebos can really help. There's a study of patients with irritable bowel syndrome in which they were given a placebo and told, this is a placebo. There's nothing in here. But there's a lot of research to show that placebos decrease pain. A third of patients got better. And there are no side effects. It doesn't cost anything. So as we're looking for ways to increase the efficiency, the efficacy of medicine, control cost, I think we need to look at how we speak and how that can play a role in improving patient outcomes. So I want to end with just the follow-up of Mr. Amadou, and then I'm happy to take some questions. When I think back to my communication mishaps with Omar Amadou, I can see more clearly how and why it was so exasperating. The geometry of our conversation went awry as we pursued divergent dialogues. Although I appreciated the severity of his cardiac disease, I was irritated by the muscularity of his insistence, and quickly pegged him as a, quote, difficult patient. My labeling of him distorted what I heard. In his persistent demands for my time, I discerned entitlement. I became resentful. Had I stopped arguing about appointments and phone calls with him, I might have been able to intuit the animating impulse of his desperation. Those of us whose luck has kept us from facing down death can't really appreciate the exquisite vulnerability that serious disease engenders. Raw fear is a motivating force like no other. When I tried to imagine being Mr. Amadou, navigating an unforgiving medical system, negotiating in a foreign language, all with a heart that was flagging long before its warranty was up, I can begin to understand his approach. Why wouldn't he insist on what he perceived as necessary? Why wouldn't he refuse to take no for an answer? But I wasn't able to fully comprehend that until his body crumpled in my office and I felt the life wicking away from him. After his faulty pacemaker was replaced and the excess fluid drained from his lungs, Mr. Amadou came for a post-discharge appointment. It was an almost intolerable relief to see his lanky frame in his trusty tracksuit filling my doorway. When I shook his hand, the hand that had been frigid the last time I'd held it, I basked in its ardent warmth. I had no illusions, of course, and neither did he. The recent tune-up did not impart any fairy dust of additional cardiac reserve. Mr. Amadou would not be doing the 200-meter dash down Lexington Avenue anytime soon. But we dodged the bullet, this time at least, and we both exhaled cautious sighs of relief. Mr. Amadou's first question, of course, was when our next appointment would be. Normally this would irritate me, but now his voice unfurled almost like a benediction. I couldn't promise that we'd never have miscommunications in the future, or that I or he wouldn't get aggravated when things didn't work out. But I could promise that I would pay more attention to how I listened and how I spoke. My favorite poet, John Stone, was a cardiologist and poet from Emory who sadly passed away a few years ago. He read his poem, Gaudiam's Igitur, to a graduating medical class some years ago. And amongst the many sage lines, he told them, "You will learn to see most acutely out of the corner of your eye, to hear best with your inner ear." A more astute lesson in communication I could hardly imagine. Thank you. Thank you, and I'm happy to take any questions. Yes?
As a student of public health and, as a student of public health and also as a patient, has anyone ever done a study on why insurance companies ignore all of the research that says that paying doctors to spend more time talking to patients reduces the need for all of these very, very expensive tests and things like that? Like, seriously.
I think that's a great question. I think insurance companies probably don't read much research, but it really reflects back on how our insurance system came to be. I mean, this was put together when, in the early days of health insurance, and it was created by the AMA in consultation with insurance company officials. But in the setup there, the doctors who were specialists were way overrepresented compared to primary care doctors. And so naturally, things that they did, procedures, surgeries, got more money. But also, those are things you can count. And for insurance companies, you can count how many endoscopies, how many hours in the OR, how many units of blood. How do you count a conversation? How do you measure an effective conversation? And so we tend toward paying for things we can count. And of course, we had a fee-for-service model. So services, things you did, things you cut, things you put in holes, got money, and things you talked about, well, anyone could do that, so that doesn't get any money. It's not considered service. But you're right, and one could only hope that when we redo our medical system, we think about that. I'm cautiously optimistic, but I'm not holding my breath. Thank you.
So thank you for sharing some of your book with us today. I'm a pharmacist, and I definitely see the issue of communicating with patients in everyday life. And there has been some kind of push towards better care, Medicare star ratings for each pharmacy that measure patient outcomes rather than how many prescriptions you filled for reimbursement. Thing is, though, I just graduated. They don't teach us in school necessarily how to effectively communicate with patients. Like, even our communications class had very specific benchmarks we had to hit, very specific questions we had to ask, without necessarily being able to ask a question based on the answer. So how do you think the education model should be tweaked for healthcare professionals to be able to teach a class and have students retain it?
Thank you for that question. So how do we teach communication skills, which is critical? In medicine, we tend to, just like insurance companies, we tend to mark things that we can measure. So we make core competencies, and we have a 1 to 5 Likert scale to measure, did you achieve this level of competence? Which again is easier when you're measuring how someone does suturing, hard to measure when you're doing how they're communicating. And so our gut is always to make a PowerPoint presentation on how to communicate, but I don't think that's a very effective way to teach communication. And the real way to do it is in the small setting with a role model who shows how it happens. And my parallel is the issue of multicultural sensitivity. It's been a big push about healthcare providers being aware of our patients' various cultural backgrounds. And again, we tend to do this with PowerPoint presentations. And I remember as a student, most of my attendings were these older white men with these starched, white coats, all buttoned up, who they never, went to the Peace Corps or traveled in Guatemala. And I remember I'd bring them to the bedside of our undocumented Guatemalan immigrants or the, alcoholic from the Bowery, thinking, how will these guys ever connect? But these old school doctors were very interested in the patient and asked a lot of questions and did a very thorough exam, and they gave the patients their full attention. And this curiosity and interest and respect made the connection. And so being told, oh, Hispanics like this and Asians like that, it doesn't really give the competency, but listening carefully and paying attention really makes that connection despite the cultural, gulf that occurs. And I think watching these doctors from very different stations in life and backgrounds in the patients negotiate a connection was how I learned it. And so it's in the small group setting. It's also making choices who we have as our teachers. So we may tend to want to get the specialist with the great research, in an area because they have a lot of knowledge, which is wonderful for one part of medicine, but we often forget about bringing in those who can model how to communicate. And it might be the nurse practitioner, the pharmacist, the nutritionist, the general practitioner doctor who spends more time talking with patients. So it's an issue of doing it in real time rather than having a slideshow. And you can't do a multiple choice test on that, but you can watch how our students communicate, one thing we sometimes do is videotape them. And I once videotaped myself talking to a patient and then watched it. And I was amazed. All these things I didn't realize I did. For example, when I think hard, I close my eyes. I had no idea. I they must think I'm asleep. I don't get any coffee. But I realized, or I talk too much with my hands. But being able to watch yourself as you talk with a patient is a great way to see, did you connect, or were you focused, were you making eye contact? And there are now systems. One of the systems that I go through in the book is called the rotor system of communication, which divides up all the statements you make into statements that questions of information, questions of explanation, statements of empathy, questions of understanding. And then you can actually tally up how much someone spoke and what they said and what the patient said. And you can see, boy, the doctor repeated the same thing 10 times, but never once reassured the patient. And these are ways that we can actually get better. Boy, I'm missing the boat on there. Another example is helping patients take their medications, medication adherence. So as we know, something like less than half of the prescriptions we write get filled and taken as the prescription says. And some of these medications are very important, so many patients are missing out on the full benefit of that. And so how do we doctors respond? We kind of harangue our patients. Well, you've got to take them. You're going to end up blind, amputated, in a wheelchair. You have a stroke and a heart attack. And we bring out all the horrific things, and that doesn't work very well. But we could keep doing it because we don't really know any other ways. And a wonderful study by Heidi Hamilton at Georgetown, she videotaped doctors and patients speaking, and then she interviewed them both afterwards. And what was fascinating is that all the information about why the patients couldn't take the medications were right there, but only in the post-visit interviews when the patients spoke candidly about the cost of medication, or that it caused sexual dysfunction, or that it made them feel sick, or they were embarrassed to use syringes in public, or they cut them in half to make them last. All these things that were the real reasons they couldn't take medications, but it never came up in the doctor-patient visit, partly because the doctors never asked. And so lesson I took from that, sometimes when in the middle of my harangue about, change your white rice to brown rice, more fruits and vegetables, eat your broccoli, I might stop and ask, what's the hardest thing about having diabetes? And if I remember to ask that, the most important things come out. And it could be the social pressures of family, the walking down the street and the food that's cheapest is the worst food to eat and the healthy food's more expensive, things I wouldn't know about. And if we don't ask, we'll never find them out. So there's lots of aspects of communication that can really improve health.
Good evening, Doctor. Hi. At the risk of being booed, I've worked for a lot of health insurers, but
we need you too.
Yeah, okay. So I just wanted to ask if this is something that you covered, and you just sort of mentioned it. I used to work for Affinity Health in the Bronx, which is a Medicaid payer, and during our orientation, they showed a video. And a lot of what you just talked about it was interviews of patients. And one of the things that they talked about in terms of noncompliance in medication and not following through on courses of treatment, where they were embarrassed to admit that they didn't understand what the doctor had told them, that the course of treatment, and they were ashamed to say to the doctor, I don't understand, or ask a follow-up question. They felt either they were burdening the doctor or they felt foolish or that the doctor would look down on them. Is that something that's come up in your book, or that in studies that they've been able to talk? I mean, I'll cut it off there.
It comes up a lot. In fact, I have a patient who had very difficult to control diabetes, and his medication adherence was terrible. And so every visit, I would make this great medication list, and I would write it clearly and underline colors, and we were getting nowhere. And each visit, I tried harder to make a better medication list for him and explain each one, go through each one. It took me more than a year until he confessed to me that he couldn't read. And I'm making all these lists for him and he can't read. And he was too embarrassed to admit that. I never asked. And so for years, this man has been going through life with a bag full of medications. So now one thing I do is I ask my patients very routinely, do you smoke, do you drink, how far did you go in school, where are you from? And I'll find patients who attended third grade, as far as third grade or fifth grade or first grade, and at least I'll know that I need to be careful with health literacy because they won't be able to read the list of medications, things like that. So asking, instead of saying, are you taking your meds? Which first patients say, yeah. I'll say, many people have trouble taking all their medications. It's very hard to do. Have you ever had any difficulty taking some of your medications? And if I worded it that way, someone might be more likely to say they don't take it. My grandmother, may she rest in peace, she believed firmly in cutting every pill in half. Whatever the doctor gave, half. Cholesterol, thyroid, anxiety, whatever it was, in half. And no matter what I would say to her, she always cut it in half. And I'm sure doctors had no idea. And she wasn't doing it because of cost. She just firmly believed that whatever they gave was too much. And she had to cut it in half. And in the end, she ended up dying of a sudden event in her home, cardiac event or a stroke. And her biggest fear was ending up in a nursing home, debilitated. And maybe by cutting her, her statin in half, she didn't lower the cholesterol so much, so she got the heart attack, rather than sparing the heart attack and ending up with cancer or dementia. So maybe she did the right thing for herself, and her doctors probably never knew. And so I'm very much more humbled now when I ask patients about their medications, because there's lots that goes on. Medications interact, and we don't know if we don't ask. And the patient has the information. We just need to know how to ask in a way that's not so threatening.
If you feel that if you suggest they bring somebody with them, because we have elderly parents and one can't hear so well, or what,
Yeah, bringing someone with you can be very helpful. I mean, one caveat is often if the adult child of the elderly patient comes, the doctor often talks just to the adult child, and it's very it's very tempting because that person speaks more quickly and is more fluent in responding. We have to be careful to still address the patient to whatever ability they have. Sometimes there's dementia issues or hearing issues, but bringing someone along can be very helpful. And, the time-worn advice of, make a list before you come in, but to also recognize that if you have 40 things on the list, if you do them all, it'll be superficial. And to be realistic that you really can only get to 3 or 4 at most in any depth. And so prioritize and recognize that you can hit a couple but not all, and you can get to some at another time. I also suggest that patients at least recognize that their doctors are stuck in an untenable situation. There's way more that must be done than can be done in that time. So you have no choice but to multitask, which is a terrible thing to do. It dilutes your attention, but you'll never finish. And then you'll get dinged for being inefficient because you're running over. So one of the things I've tried to do is that I find helps is I try to let the patient talk for the first minute without writing anything down. And then I'll say, I don't want to miss what you're saying. Do you mind if I use the computer to write while you're speaking so I can get it all down? Then at least I'm acknowledging the necessary evil of the computer. We all know it has to be done, but not trying to sort of sneak away from the patient and I'll just start writing over there. And then at the end of the visit to say, is there anything else? Even though we hate to say that as doctors because you could be opening the Pandora's box, but I think by asking that, it lets patients know that, you'll have a chance to get it there. You're not going to be so anxious to get every last little thing in. So I encourage doctors and caregivers to ask, did I get this right? Let me repeat back what you said. Is this everything that you told me? Yeah. Go on.
One thing that could help improve communication is for the patient to bring a tape recorder or some kind of recording device. I've never done it because I'm sort of would feel a little, I'm not sure I don't know how the doctor would react to that question, and I wonder what your opinion is. And maybe the doctor should also record for his or her own benefit. Maybe it should be an investigation of the doctor and then give a copy to the patient or something like that.
Well, some doctors will dictate in front of the patient and then print out a copy of the dictation. And ideally, if there was enough time to record and review every visit, but I think realistically it wouldn't work for the doctor. But I think there could be some benefit. I take cello lessons, and my cello teacher always wants me to record our lessons. And I never do because what am I going to go back through 90 minutes of a tape every time? But I try to record if there's a key moment, hold on, I'll turn my tape recorder on just for those 2 minutes so I can collect the key things. So it is helpful to go back. You'd be amazed at what you forget. So I think it might not be a bad idea as long as, both parties are okay with it. Sure, give it a try.
Talking about, going over things with the patients, one thing that always strikes me, and a lot of doctors do this, is where they'll go over stuff with you that happened during the appointment, but they won't go over the discharge instructions. So I went with a friend of mine to urgent care the other day, and the doctor did a very good job of asking her if she had any questions or anything. But then the discharge paper wasn't until you exited the office and it was picked up at reception. And so we get home and she looks at it and she says, you know, the doctor said to me that if I wasn't feeling better in a few days, I should take this antibiotic because she'd been prescribed medication for an upper respiratory infection and then a wait and see antibiotic. But on the discharge instructions, it says delayed or wait and see, but it doesn't say how much time. And I looked at it and she was absolutely right. And so she had to, while feeling ill, go find the number for the urgent care, call them back, have the doctor's name, and so on and so forth. And this seems to be a problem where discharge instructions tend to be given to you outside of the doctor's office by a reception. So if there's anything on it that confuses you, the doctor's already off seeing another patient. And you have to, wait an hour and a half to see the doctor.
It's a great question. I think the point of leaving, of parting ways, whether it's from a visit or from the hospital, is a very fraught moment. And in fact, when they interview patients leaving the hospital, most of them don't even know their own diagnosis or their doctor's name, which is strikingly, but they do know their nurse's name, interestingly, much more than their doctor's name. Probably because nurses spend more time in the room and are touching more. And so every time we sort of part ways is a good, time to, remind ourselves to stop and say, okay, here are the top 3 things you have to remember. And here's my name. I do that again because patients forget. I forget their names. They forget my name. So to remind them again, here's my card. My name is Dr. Ofri, and here's how you can reach me if you forget something. We forget how much happens in a visit and how hard it is to remember, especially if you're in pain or feel sick or frightened. It's very hard to retain information. So thank you for that question.
I believe we have time for one more question.
Thanks. I guess my question is really, related to specific populations that may have issues with memory or whether it's something with Alzheimer's or it's like TBI or if it's, of all different ages. What is the doctor's responsibility in terms of ensuring that there's compliance with treatment? I guess if the patient themselves is not reliable, then who is it that steps in, to be able to do it if the patient's not necessarily capable of doing that on their own?
That's a tough ethical quandary. If the patient isn't able to do, all the things they're needed to do, who steps in? It depends on the level. So if the patient doesn't have decisional capacity to make a decision, that's a legal definition, in which case someone has to be appointed legally, a guardian, that then can make the decisions. But short of that, if a patient, has capacity, has a basic understanding, but isn't quite taking the medications well, you can only try to help that patient with getting a visiting nurse or a home attendant or encourage the family, but you can't really enforce anything, and you can't realistically or logistically be responsible for the patients taking that. But it's trying to help the patient get the services that they want if they're amenable. The problem I found is that the patient doesn't want any services. I don't want anyone in my home. I don't want anyone coming near me. That's tricky. I had a patient, an elderly woman, who has a family, but she's really, getting frail. And I suggested hospice and home hospice, and they were horrified, the family, because that means death, and they really didn't want to do it. But then I can urge them to give it a try. They were so thrilled with the hospice care. It's been more than a year on hospice. I spoke to the family this morning, and the patient's doing fantastically. That the additional help, in fact, improved the patient's functioning and abilities much more. So sometimes it's getting over the stereotypes of what home care or hospice means, helping patients take that step, and seeing that in fact it usually makes things much better. But it's not always so easy. But thank you. So thank you very much. I'm happy to answer any more questions, sign any books, and thank you very much. Have a wonderful evening.